Hello doctor and medical students, I am Dr. Amit. So in the last video from our endocrine series, we discussed about how to categorize a patient with hypertension and hypokalemia into primary, secondary and aldosteronism. Now today we'll move forward in our endocrine series, and today we'll discuss about primary hyperaldosteronism, its clinical presentations, how to diagnose a case with primary hyperaldosteronism and its treatment part. So as we already know that primary aldosteronism should always be suspected in a patient with hypertension and hypokalemia. So while talking about its most common cause, the most common cause is aldosterone producing adrenal adenoma and bilateral adrenal hyperplasia. Now let's talk about its clinical presentation. So the patient will present with hypertension, metabolic alkalosis, hypokalemia, mild hypernatremia. Now, why metabolic alkalosis? Because aldosterone will secrete out potassium and H plus from the body, so there will be less H plus in the body, so that will lead to metabolic alkalosis. Now let's talk about its diagnosis part. So we all know to diagnose a case of primary hyperaldosteronism, we need to measure the plasma level of aldosterone and renin level. So there will be increase in plasma aldosterone level and decrease in plasma renin level. Then after that, the plasma renin activity, or we can say that plasma aldosterone to plasma renin activity will be more than 20, and that will suggest a primary hyperaldosteronism case. Then to confirm the diagnosis, we do adrenal suppression testing by oral saline load. So oral saline load is simply what in a normal person, when we give salt or oral saline load, then that will lead to suppression of aldosterone secretions. But in a primary hyperaldosteronism case, there will be no suppression of aldosterone release. So this will confirm the diagnosis. After then we can do abdominal imaging, that is CT scan. Then to differentiate between unilateral adrenal adenoma and bilateral adrenal hyperplasia, we do adrenal venous sampling. So now we'll move forward into a treatment part. So while talking about a treatment, in treatment course for unilateral adrenal adenoma, we preferred surgery, but we can also give aldosterone antagonists like spironolactone and eplerenone for poor surgical candidates or the patient who refuse surgery. Then in case of bilateral adrenal hyperplasia, we always prefer aldosterone antagonist. So among aldosterone antagonists, spironolactone and eplerenone, spironolactone is the initial preferred medical therapy. But there are some side effects of spironolactone, like spironolactone is progesterone and androgen receptor antagonist that will lead to a decrease in libido and gynecomastia in case of male, and breast tenderness and menstrual irregularities in case of female. But while talking about eplerenone is a very selective mineralocorticoid antagonist with very low affinity for this progesterone receptor and androgen receptors. That's why they have a fewer endocrine side effects. And the last is there is no peripheral edema in the patient of primary hyperaldosteronism due to aldosterone escape mechanism. Thank you.